Well, good afternoon, all. We're going to continue on with our spinal cord injury lecture series. I'm Dr. David Gator. If you can hear me, give me a thumbs up, just so that I know that, okay, good. Just so at least we're on board and moving forward. So we're going to be speaking about the neurogenic bladder after spinal cord injury. If I can get moving here, we will anyway. There we go. So I'll be talking through the definitions for different types of neurological bladder dysfunction. We'll talk through the epidemiology and then obviously the anatomy, physiology, particularly with regard to innervation. And that will include the somatic as well as the sympathetic and parasympathetic nervous systems. We'll talk through clinical management strategies and towards the end, we'll go into the more invasive type of procedures that are necessary to control certain types of neurogenic bladders. So the guidelines, hopefully you're familiar with these, but the guidelines were put forward in 2006 and I think are undergoing revision even as we speak. Those of you who have not seen the consortium guidelines before, these are put forward, sponsored by the Paralyzed Veterans of America, and include a number of supporting organizations who vet these recommendations before they actually come into clinical practice guidelines. So basic anatomy, we're going to talk through the upper tract, which includes the kidneys and ureters, as well as the lower tract, which is the bladder, urethra, and sphincters. Hopefully this is not new to any of you moving along. Recognize that as we get down to the lower tract and we worry about increased reflex excitability, particularly with regards to the external sphincters, we're going to be talking through the external sphincter and pelvic floor musculature as well, because that increased reflex activity does have significant issues with regard to bladder outlet obstruction, or BOO, as we'll talk about a little bit more. So micturition is the process of emptying the bladder. As it becomes filled, you have a stretch mechanism that increases afferent activation and subsequently causes reflex bladder contraction with relaxation of the sphincters. The opposite of that, obviously, is, boy, I just talked through that backwards, but bladder emptying is the act of micturition. The bladder filling is actually as you relax the detrusor and allow it to fill. So we're going to talk through the innervations of this as it relates to a 2x2 kind of functional output. So the bladder is one of those twos that can be too much or too little bladder function. And so if you have too much bladder function, then you're at risk for neurogenic detrusor overactivity. Too little, and you have acontractility, which can lead to a big boggy bladder, B cubed. Then you also want to take a look at the other twos, that is the sphincter function. And so if the sphincter is too tight, we end up having detrusor sphincter dysenergia, high pressure systems that can cause vesicoureteral reflux and subsequently acute renal failure. If the sphincter is too loose, on the other hand, then you have intrinsic sphincter deficiency. And that can be caused through several different things. We're going to talk through specifically the flaccid neurogenic bladder and sphincter as we look through that. So what I'm going to do is provide a graph, if you will, that looks like this, where we're going to be looking at bladder contractility on the x-axis with low contractility on the left side of this and high contractility on the right side of it. And then we're going to look at sphincter contractility on the y-axis. Again, too little being down towards the bottom of this and too high up towards the top of the balance. So Obviously, what we're trying to achieve in our folks with neurogenic bladder is the ability to balance bladder contractility and sphincter contractility to maintain appropriate continence without putting the upper tracts and the kidneys at risk. So in order to fully understand this, we need to step back for a moment and recognize the bladder innervation. And I'm going to start down at the bottom of this, the somatic nervous system, which provides efferent information. S2, S3, and S4 provide inputs to the pudendal nerve and controls the external sphincter and the pelvic floor musculature. For just a moment then, take a moment, because you can voluntarily contract your external sphincter and pelvic floor musculature. Just recognize that that is there to help maintain continence, but it can lead to incontinence if you have significant sphincter dysergia, sphincter detrusor dysynergia. The sympathetic nervous system is mediated through the hypogastric nerve. So components of T10, T11, T12, L1, and L2 all contribute to the hypogastric nerve. The hypogastric nerve is shown in this slide as several different nerves, and they provide sympathetic influence to cause detrusor relaxation through beta 1, bladder neck contraction, alpha 1 receptors, and then ultimately this is going to lead to bladder storage. The parasympathetic nervous system rises from S2, S3, and S4 nerve roots to form the pelvic nerve. Parasympathetic activity causes detrusor contraction through the release of acetylcholine, and subsequently we have voiding. So long as those are all coordinated. So I want to take a moment again just to talk through the parasympathetic, sympathetic, and somatic neurotransmitters. So the parasympathetic nervous system, remember, has acetylcholine receptors at its terminal regions, and those receptors basically are muscarinic 1, muscarinic 2, and or muscarinic 3, recognizing that only muscarinic receptors, again, these are cholinergic receptors, mediate detrusor contraction. The sympathetic adrenergic receptors, so these are going to be influencing alpha 1 receptors, are going to lead to bladder neck contraction. So sympathetic influence causes bladder neck contraction through the alpha 1 receptors. And then the beta 3 receptors actually are going to contribute to detrusor relaxation. And we'll talk through the pharmacology of that in just a few minutes. And then finally, you have somatic cholinergic nicotinic receptors. And again, this provides voluntary control over the external sphincter. That is a skeletal muscle. And so under normal circumstances, you have voluntary control over that. You don't necessarily have control, although you can contribute to bladder evacuation through doing a Valsalva type of maneuver as you talk about emptying. First, let's talk about bladder filling. So bladder filling is influence of sympathetic nervous system, parasympathetic nervous system, and somatic nervous system. So under conditions of filling, the increased sympathetic nervous system is going to allow for detrusor relaxation, bladder neck contraction, and bladder storage. You're going to have a decrease in parasympathetic nervous system influence along the pelvic nerve, so that you end up with a actual decreased detrusor contraction, and this is going to allow for bladder filling as well. And then again, the pudendal nerve allows control of the external sphincter, pelvic floor musculature. As you contract those, you're going to have bladder filling. And just to put a little bit more spin on it, again, bladder filling is that situation in which you have significant sphincter contractility, and bladder relaxation. So bladder emptying, on the other hand, is going to reverse these scenarios. So now you're going to have a reduction in sympathetic influence, so less, if you will, detrusor relaxation. You will have bladder neck relaxation because of the decreased sympathetic nervous system on the alpha-1 receptors. Your parasympathetic activity is increased along the pelvic nerve so that you have detrusor contraction, and this is going to facilitate voiding so long as your external sphincter and pelvic floor are relaxed. And so a reduction in somatic influence allows for bladder voiding. So as the detrusor contracts, you're going to see increase, in this case, bladder contraction mediated through parasympathetic influences, and sphincter relaxation, so that you end up ultimately relaxed sphincter, good outflow as you're going through that. So that being the normal physiology, let's talk a little bit about the abnormal influences of a spinal cord injury. So if you have an upper motor neuron, that is spinal cord injury, you're going to have spasticity. Spasticity is going to be mediated both at the detrusor as well as the sphincter. And so you have detrusor sphincter dysinergia, generating a high pressure bladder. That is going to cause vesicoureteral reflux, because when you contract both sphincter and bladder, the urine can only go one way. Subsequently, we see hydroureter, hydronephrosis, acute renal failure, and death in some circumstances, which is suboptimal. The lower motor neuron bladder is areflexic, and so this is where typically you have a conus or a cauda equina type of injury to the sacral, afferents, and or efferents. So you end up with a flaccid bladder and a flaccid sphincter. So you end up with a situation with overflow incontinence and a big boggy bladder. Okay, so this is what you see down below. Up above, you see a small evil bladder, is how Dr. McGuire at University of Michigan used to describe this. Small, contracted, high pressure system. So again, coming back to our bladder pharmacology. So acetylcholine through parasympathetic influences is going to cause detrusor contraction. Sympathetic influences on beta-3 receptors is going to relax, basically. And then your external urethral sphincter, the pelvic floor musculature, are under somatic control. Again, that's cholinergic in nature. So let's talk about how we can assess these different tracks as we're looking through it. We are going to consider using our renal panel. Recognize that most folks with spinal cord injury are going to end up losing a significant amount of muscle mass. And so their creatinine is going to be diminished. And it's not unusual to see creatinines 0.4, 0.5, really low as we're looking at that. We should take a look at the 24-hour creatinine clearance to give an idea of the physiology of the system. We can use cystatin C, which is independent of the muscle mass, and gives us a fairly good idea. But really, most of the time, we're going to have to move forward with actually visualization of the upper and lower tracts. So we can do a nuclear renal scan to tell us how active each kidney is. And it's not unusual to see a scarred down kidney on one side or the other, and in some cases both. We will be looking at annual renal ultrasounds, taking a look to make sure that the upper urinary tracts are intact. We don't see hydroureter or hydronephrosis. Depending, we may need to get an abdominal CT, specifically if we're looking for bladder calculi or ureteral renal calculi. When we look at the lower tracts, we can do this through cystoscopy. So that actually you pass a scope into the bladder itself, looking for trabeculations, looking for stones, looking for other types of lesions. Typically, we'll do urodynamics annually or biannually, and then intermittently do a voiding cystourethrogram. So we'll talk through what that looks like as well. So of greatest concern for me as a clinician is the integrity of the upper tracts, that is the ureters and the calyces of the kidneys. As we go through this process, we're also going to be looking at lower tracts. So hydronephrosis, again, is looking at the integrity of the kidneys. What we want to see is a lot of parenchymal tissue around here. What we don't want to see, this is called grade 4 hydronephrosis, is where you have almost no remaining, the calyces have been completely filled with fluid, no remaining parenchymal tissue for the kidneys. What that means is that you don't have, what is the workable unit? The nephrons basically are going to be eradicated as we get to this point. We never want to get to this point, which is why we assess as frequently as we do to make sure that we're not developing grade 1 or grade 2 hydronephrosis, which could ultimately end up as a grade 3 or grade 4 acute renal failure and death, or hemodialysis, neither of which are optimal. So typically we are going to be looking at urodynamic studies. So on the x-axis, typically I'm looking at EMG activity, and I'm looking at the volume. Whoops, let me go back one. So as we fill the bladder, we should see increased EMG activity. The person should be able to start their flow, stop the flow, and then start it again upon request. And we should see relatively low pressures as this goes through. Normal situations, that's what we see. Under conditions of spinal cord injury, however, as we are filling, even low volumes will cause reflex contractions of the sphincter as well as the bladder itself, the detrusor. And so as you see these, you start to see spikes, spikes of EMG activity and spikes of bladder contractions as we go through there. So typically what we're going to be looking at is our tracing, where we have a catheter in the rectal vault, a catheter in the bladder itself, and then we're going to be subtracting out the rectal from the bladder catheter so that we can determine what the true detrusor pressure is. We want to see this pressure less than 40 centimeters of water. If we have pressure within the bladder for any sustained period of time, other than when we're voiding, then we're at high risk for developing hydroureter, because it changes the conformation of the ureters as they come into the bladder. And as the bladder stretches, the pressure goes up. Then you can push the urine, unfortunately, right back up the ureters to the kidneys. So this high pressure bladder is the one that I'm really concerned about, because it can cause upper tract deterioration, and it's a result of detrusor sphincter dysynergia. Not quite as concerned about a low pressure bladder, so long as I can provide intermittent catheterization frequently enough not to have high volumes that would put the person at risk for urinary tract infections. And that's the case that you see with lower motor neuron injuries. You're going to see detrusor sphincter areflexia. And so again, overflow incontinence, not uncommon in that kind of a scenario. So this situation of causing high pressures, though, high pressure for you or I would really hurt. And we would feel that and respond appropriately. A person with spinal cord injury doesn't get that sense of pain necessarily. And in fact, what they see instead is, in response to afferent information coming from the bladder, a reflex sympathetic outflow causing splanchnic vasoconstriction, hypertensive crisis, stroke out and die, suboptimal. So what does that look like? Again, we know that the bladder issues in spinal cord injury are the one cause of autonomic dysreflexia. So whether it's bladder distension or stones or a combination of the two, a noxious stimuli below level of the spinal cord injury will send afferent signals up the cord, but blocked at the level of the injury, with a reflex sympathetic outflow causing splanchnic vasoconstriction and, as I said, hypertensive crisis. Increased pressure is sensed by baroreceptors that send information to the medulla, which sends information back to the heart, causing a reflex bradycardia. But below the level of the injury, the person remains vasoconstricted. Above the level of the injury, we see flushing, sweating, and a pounding headache we call autonomic dysreflexia. So again, urological causes are the #1 cause of autonomic dysreflexia and can include bladder distension, bladder calculi, renal calculi, not trig, not geometry, but calculi, urinary tract infections, bladder spasms, trauma and cancer. All of these can contribute to autonomic dysreflexia and are preventable. So as clinicians, we need to be aware that these things could occur, and we need to do everything we can to prevent them from happening. So the goals of bladder management essentially are to preserve the upper tracts, to try to prevent infections and stones, to provide urinary continence, to improve quality of life, and to provide patient satisfaction physically, economically, and socially. So goals, as you know, need to be SMART goals, that is specific, measurable, attainable, relevant, and timely. So let's talk through why we would want to have those goals. In 2004, Kim Anderson was here at the Miami Project. She sent out a survey to people with tetraplegia as well as paraplegia and asked them what function is most important. Those with tetraplegia reported that almost 50% of them said arm and hand function would be the most important thing for them to regain, but bladder and bowel dysfunction, including autonomic dysreflexia, ranked 9%. Those with paraplegia, 18% of them reported that bladder and bowel dysfunction is what they're most concerned about. And so recently, the Nielsen Foundation worked with NIH and NIDLR to put together appropriate strategies for providing research for spinal cord injury bladder management, including preclinical outcome measures. That means animal models, basic science, looking at tissue morphology, voiding dynamics, cystometry, and metabolic cages, again with animals. And then clinical outcome metrics that include objective voiding diaries, laboratory examinations, imaging studies, urodynamics, and cystourethropy. Also, the consumers really wanted to be able to provide self-report quality of life metrics. And so the Qualavine 30 and the short form Qualavine were recommended, as well as the International Lower Urinary Tract Function Basic Data Set. So these are options. The residents should have access, the residents and APPs, to our quick set orders. So recognizing that as soon as possible, we want to get the catheter out of the bladder when it's safe. So once our bladder volumes are less than 2,500 cc's or less than 2,000 cc's, then we can replace the indwelling catheter with intermittent catheterization protocol, and thereby reduce the risk of catheter-associated urinary tract infections. ICP should include sterile technique in the hospital every 4 or 6 hours, documenting the volume, and then contacting the house officer for volumes greater than 500 cc's. Can I see a show of hands of how many residents have been called for a bladder volume greater than 500 cc's? I'm looking, I'm not seeing. Either you've lost your hands or we're just not getting contacted. And I can't believe you lost your hands. So, so this is something that we need to work with our nursing staff a little bit more to improve the communication, because as a resident physician, I always wanted to know as an attending physician, I certainly want to know if bladder volumes are exceeding 500 cc's. Why? Because you're putting people at high risk for upper urinary tract dysfunction. So for incomplete spinal cord injury, the intermittent catheterization protocol should be administered with lidocaine jelly and then document the volumes. I will sometimes use an external catheter. So for example, if somebody has a sphincterotomy and or a urethral stent, that's okay with me. We can use an external catheter, a condom catheter, if you will, and then document. Then what I want to know is the 24-hour urine output. For an indwelling urethral catheter, I want to know the 24-hour urine output. It should be less than, I'm looking for something under 2,500 cc's. If a person is going to need long-term indwelling catheter, I would prefer using a suprapubic catheter over indwelling urethral catheter, because there are less urinary tract infections associated with that and less likelihood of stones, bladder stones or renal stones. Avoiding trial is provided, offering a urinal every 4 or 6 hours, documenting the volumes. And I want to document the post-void residuals as well. So ideally, I would like to see the post-void residual less than 50. I can deal with it if it's consistently under 100, but I worry about those folks getting a urinary tract infection. So once I've seen PVRs 3 times with volumes less than 50 cc's, then I will discontinue the intermittent catheterization protocol until such time as I see an increased reflex activity occurring. So either the presence of a bulbar cavernosus reflex and or significant reflexes at the knees and ankles. At about that time, I'm also going to start to have external sphincter and detrusor concomitant reflex activity that could generate high pressure volumes again. So why intermittent catheterization? Ed McGuire at University of Michigan in the 70s promoted this as a much better way of managing the bladder than leaving in indwelling catheters and or not managing at all. So, you know, up to that point, the 60s and 70s, we had a high incidence of folks dying with urinary tract infections, urosepsis, and upper tract dysfunction. So intermittent catheterization will allow for fewer complications, particularly a reduction in calculi, both bladder and renal calculi, a reduction in urinary tract infections, and a reduction in transitional cell carcinoma, which can occur typically when you've got an indwelling urethral catheter. The goal of intermittent catheterization is to have bladder volumes under 500 cc's with a post-void residual less than 50 cc's and continence. The usual practice in the hospital is using sterile technique. At home, ideally the person and or their attendant is going to be able to use clean technique without getting urinary tract infections. Now we do have the touchless catheters, and those are ideal to, again, reduce the number of urinary tract infections. So this is desirable for folks who have sufficient hand skills and those with caregivers who are willing to do this. Now, what is sufficient hand skills? Typically, a person with C6 tetraplegia would be able to use tenodesis to be able to do intermittent catheterization. But I think the literature only shows somewhere around 25%, 33% of those folks actually being able to do this independently, either because of microphallus or potentially they don't have long enough arms, they've got too much girth, they simply can't pass the catheter. So consider alternatives if the person has abnormal urethral anatomy, so you've got scars and strictures that are preventing intermittent catheterization. If your bladder capacity is less than 200 cc's and you're drinking 2 liters a day, that means you would have to cath at least 10 times daily to make sure that you didn't have problems with autonomic dysreflexia. If the person is unable or unwilling to adhere to a cath schedule, If their high fluid intake doesn't allow for intermittent catheterization, if they're having autonomic dysreflexia as the bladder fills, or some folks just have an adverse response to passing a catheter multiple times a day. So if we're going to recommend, and I usually do, intermittent catheterization, recognize that it can be associated with urinary tract infections, bladder overdistension, urinary incontinence, urethral trauma, false passages, urethral strictures, autonomic dysreflexia, and bladder stones. However, the incidence of these are significantly fewer with intermittent catheterization than with indwelling catheters. And so this is still my go-to whenever possible. Urinary tract infections. Now, recognize that we're talking about significant bacteriuria in the presence of significant pyuria, that is white cells, nitrite and leukoesterase positive on the urinalysis. That said, if I don't have signs and symptoms, I still may not treat this. So the signs and symptoms would include fever, rigor, pain, malaise, autonomic dysreflexia, spasticity that is new and different, cloudy odorous urine, and new incontinence. All of those signs and symptoms in the presence of significant bacteriuria and an elevated white count with nitrite positive, leukoesterase positive, that would indicate a urinary tract infection that I would want to treat. Now, let me just warn you, don't routinely get urine cultures if you're not going to do a urinalysis, because you're going to see bacteria. Bacteria is going to, you're going to colonize. You're going to have a group of bacteria, all the same kind. And this colonization does not represent a urinary tract infection unless you have the associated symptoms from the previous slide, as well as significant pyuria. So we recognize that generally speaking, individuals are going to develop a flora, bacterial flora. Oftentimes it's E. coli, sometimes it will be another type. If it's not associated with symptoms, if it's not associated with pyuria, I simply call it bacteriuria and not urinary tract infection. I don't want to overtreat, because then I develop superorganisms and then we run into major problems as we go through there. On the other hand, some folks will develop recurrent urinary tract infections. As I hear somebody getting more than 3 infections a year, I start to wonder, you know, what is the potential cause there? Are they using an indwelling catheter? Are they using an inappropriate catheterization technique and or multiple attendants? Or do they have stones? Stones and indwelling catheters are 2 of the primary culprits for causing urinary tract infections. The other possibility is the person has a diverticulum. So the same way you get a diverticulum in your gut, you can get it in the bladder. And this is simply a pocket, if you will, where the bacteria all go in there and they start to party and develop urinary tract infections. You treat that with with an antibacterial agent, antibiotic, and then they all go and they hide in that little space until there's no more antibiotics around, and then they start to reemerge again. They do the same thing in the stones. So the bacteria will climb into the stones and just lie in wait there until the antibiotic is no longer present, and then they will take over again. And that's why we end up with these recurrent urinary tract infections. So can we prevent those? It's not routinely indicated. If you've got a situation like that, I will try mandelamine. It's kind of my go-to. So methenamate with a high vitamin C content, low pH, can potentially, in studies back in the 90s, have demonstrated to be efficacious. But since then, we've had really equivocal results. Some folks will just treat with nitrofurantoin. And again, generally, my experience has been that all you're doing is creating resistant organisms when you do that. Cranberry tablets, there is some literature to support, but in general, again, the literature is equivocal, and it's not routinely recommended that we use any of these methods. And that instead, we try to figure out what could be contributing to these recurrent urinary tract infections instead. So Crede and Valsalva maneuver, this is where you're applying suprapubic pressure to express urine from the bladder, and using a Valsalva, contracting the abdominal muscles for those folks who have that ability. Consider this for lower motor neuron injuries that have low pressure and low outlet resistance, or for those with a sphincterotomy and an external catheter. I don't recommend this, and neither does the consortium guidelines recommend this as a primary method of bladder emptying, because you put people at high risk for upper tract deterioration. So again, avoid the Crede and Valsalva for those folks who have DSD, bladder outlet obstruction. Boo. Oh, that was earlier this weekend, wasn't it? But for now, bladder outlet obstruction. Vesicoureteral reflux. Again, we're trying to prevent this. And so if you use Crede and Valsalva, you're likely to cause vesicoureteral reflux in those folks with particularly upper motor neuron bladders. Those with autonomic dysreflexia and an expanding syrinx because of the high blood pressures associated with bladder dysfunction. Indwelling catheters, this is a last resort. So if the person has poor hand skills, high fluid intake, and or cognitive impairment and substance abuse, if they don't have a caregiver that can provide timely intermittent catheterization, then I would consider using an indwelling catheter. For those who have significant wounds, we'll talk about pressure injuries in an upcoming lecture, and we need to keep from soiling those wounds with urine, then I would consider using an indwelling catheter. But typically, again, I would go to suprapubic rather than an indwelling Foley in that circumstance. If I have recurrent urinary tract infections using an indwelling catheter and or a suprapubic catheter, consider using a silver impregnated catheter or hydrophilic catheters, where it's less likely that you'll develop these urinary tract infections. So I've mentioned suprapubic catheter, again, coming in over the top of the pubis. This is for those folks who need an indwelling catheter but have had problems with urethral indwelling catheters, either because of discomfort or abnormalities, skin breakdown, prostatitis that is recurring, urethritis, etc. So these are all indications for a suprapubic catheter. Recognize that indwelling catheters, be they urethral or suprapubic, can contribute to bladder and kidney stones, erosions, epididymitis, recurrent urinary tract infections, bladder cancer, and you can see the list goes on. Consider reflex voiding, I would say almost never, but the guidelines do say to consider it for those folks who have hand skills that are able to manage the condom catheter, empty the leg bag as necessary. Those who are poorly compliant with fluid restrictions, have small bladder capacities, and small post-void residual volumes. However, again, I have seen more problems with reflex voiding than I have even with indwelling catheters, so you can get my sense on this. Whenever possible, I want to do intermittent catheterization. That's a better option than indwelling catheter, and that's a better option than reflex voiding. But that's my perspective as a clinician. The patient's perspective may be different, and they might want to try this. And so recognize that in providing them this option, we also recognize that they have to do urodynamic evaluations so that we can determine what kind of pressures they're developing. And these are the complications associated with reflex voiding, none of which are very good, some of which can actually kill you. So trying to prevent autonomic dysreflexia, trying to prevent high pressure bladders and acute renal failure, these are all important things to consider. So pharmacologically, what can we do? Alpha blockades for urethral relaxation and relaxation of the trigon of the bladder, antimuscarinics for detrusor relaxation, I'll talk a little bit about the new beta-3 adrenergic agonists that also contribute to bladder relaxation, and then Botox. So the alpha blockers are going to help open the urethra near the prostate. You don't want to use these in folks who have symptomatic hypotension. Why? Because it'll cause them to pass out. So typically when we initiate an alpha blocker, we're going to be using it at night while the person is already lying down. Recognize that those folks who are using alpha blockers are also going to have to be careful using the erectile dysfunction drugs. That's a separate lecture coming up in a couple of weeks. So the non-surgical therapies for detrusor sphincter dyssynergia include these alpha blockers, I've used all of them at different times. Depends on the person's acceptance, and some people tolerate some of these. I can tell you phenoxybenzamine is a great medication, but it's very, very expensive now. And I really don't know why, because it's been around longer than all the others, but I think it's a matter of supply and demand. Terazosin, tamsulosin, prazosin, equally effective, and it really depends on the person's response to the medications. Using antimuscarinics, recognizing that we're going to be trying to block the M2, M3 receptors. So oxybutynin is the one that is tried and true, but it also has the greatest side effects, particularly sedation, dry mouth, and constipation. And so, whoops, as I see that, I recognize that I want to move on to a different option. And so there are newer selective M3 agents, and I have them listed out here, all of which have fewer side effects and are well tolerated, much better tolerated than, for example, oxybutynin, but at a relatively high cost. And so you'll have to work with your insurance companies and your patients to determine what is going to be the best fit for them. I want to use the least expensive drug that will allow a person to maintain continence. And I think that that's an appropriate goal. The new beta-3 adrenergic agonists, so Mirabegron basically promotes detrusor relaxation. And so it's also used when you have significant problems with detrusor overactivity. So in combination with established antimuscarinics and or Botox, this can really be a game changer for some folks and allow for improved bladder capacity, detrusor compliance. So Botox can be injected into the detrusor and or the sphincter, depending upon where you're particularly having problems. If the issue has to do with high pressures generated, then you might want to consider both, but you want to maintain continence. And so that's the consideration and the offset there. Typically, they will do this under cystoscopy and go in and do a number of sites within the detrusor itself to, again, cause relaxation, recognizing that the effects of the Botox will wear off in about 3 months. For some folks, it lasts a little bit longer, but you need to keep track. If you're using this for bladder management and 3 months down the road, somebody starts reporting more and more autonomic dysreflexia, recognize that it's probably the Botox has worn off and we need to re-inject. So avoid Botox for those who have neuromuscular diseases or who are allergic to Botox, those taking aminoglycosides antibiotics, or can't use a condom catheter. So complications using the injection, the Botox injection, you might get autonomic dysreflexia during the injection itself. You might see some hematuria in the blood in response to the injection as you go through there. What are the other options basically to prevent bladder outlet obstruction? So putting into place an endourethral stent that will hold the urethral open. This is going to require a condom catheter for men. It's an alternative to an external sphincterotomy. I'll talk about those in the next slide, actually. Consider this for folks who can't do intermittent catheterization, but can use condom catheters. and consider this as a basically, this will allow the person to have bladder continence so long as they can use an external collection system. The sphincterotomy is used in lieu of the stent itself. The problem with the sphincterotomy is often it rescars, and so you end up having to replace it down the line. Electrical stimulation, we'll talk about functional electrical stimulation to stimulate bladder contraction, bladder emptying. These systems, they used to be commercially available in the United States. They lasted about 3 years, and then they couldn't sustain. So the Vocare bowel and bladder system by Neurocontrol unfortunately went out of business, and they're still hoping that Medtronic or somebody like that will pick this up. This system is, or a similar system, the Brimley bladder system is used in Europe with some success. Currently only available in the United States under research trials. And the potential complications of this system. Initially, folks were having to do dorsal rhizotomies that led to a loss of sacral sensation, and subsequently those who could achieve reflex erections subsequently couldn't afterwards because you've cut the afferent input as you're going through there. So other options in my remaining time, bladder augmentation. This is where you actually, the bladder is that small evil bladder. You're going to try to increase the bladder capacity by essentially sewing in a portion of intestine. This is going to reduce the bladder pressure. They scrape this portion of the intestine before they sew it on so that it produces less mucus. That's one of the major side effects associated with this is mucus production. You can combine this with an abdominal stoma as well. There are a number of continent urinary diversions that can be used. So again, using a segment of bowel connecting ureters to the abdominal wall, and the person can actually cath this itself. You can also, in cases of bladder cancer, basically sew the urethras into this portion of bowel and use that as a ureteral ileostomy. Other options include the Mitrofanoff, and basically you're taking a portion of the appendix. You're basically providing a catheterizable stoma through what would have been the umbilical, and instead you're leaving a flap there that closes as the bladder is filled, but then can easily be passed, a catheter can be passed through there to empty the bladder as you go through that. So I've run through an awful lot of information very, very quickly. Here are some references, and we have just a couple of minutes left for discussion. I'm looking to see if there was anything in the chat that came up. Not seeing anything at the moment. Any questions, thoughts, concerns? Most of you have managed to some extent the bladders on the inpatient services. Hopefully the order sets that we've provided have been helpful to you. But the rubber meets the road when we really send these folks out of hospital and then see how they manage their bladder. And as reflex activity increases, what can we do to maintain continence, quality of life, and keep their bladder pressures low so that we don't have these upper tract dysfunctions.
Hi, Dr. Gator. Great presentation. I had a quick question about a patient we actually had on the spinal cord injury service about 2 weeks ago. It was a gentleman in his late 30s. He had a gunshot wound to about mid-thoracic level, I think like T10 or T8. So he was, he did have paraplegia, but in terms of bladder management, he presented more like a lower motor neuron bladder, So we had him on an intermittent catheterization protocol Q4. Volumes were good, like 300. Didn't have any urinary tract infections, but he persistently complained about urinary dribbling in between cath volumes, and we would do poised void residuals. They'd be 0 after cath. At first, we thought, well, maybe he's having bladder spasms. We tried oxybutynin. It didn't resolve the issue, and so. I think, he was discharged and we gave him supplies for caths as well as condom catheterizations. And I guess my question would be, long term for this patient might be a candidate for like a suprapubic catheter, given that he seems to be continuing to have very poor sphincter function. While inpatient, is there anything that we could have done to address, other than just the intermittent cath Q4, condom cath at night and during therapy? Is there anything that we could have tried to address this, or is that more kind of a long-term issue that needs to be addressed?
Imipramine. So you use nortriptyline, you use amitriptyline. Imipramine can be used 10 milligrams once a day, can be just enough anticholinergic to maintain patency. To maintain contractility of the urethra and the trigone. And so sometimes that's just necessary. If he's truly at a T8 or T10 level, he was probably still having spinal shock associated with this. And chances are that as he comes out of that, he will start to have more incontinence. So then it's a matter of managing the detrusor, either through the beta-3 agonists that we talked about and or anticholinergics. Potentially, I have at times used a combination of anticholinergics, alpha blockers, and imipramine in order to get where I needed to go. But typically, I use urodynamics to help me define that degree of dysfunction. But imipramine, 10 milligrams once a day, usually was sufficient to manage the type of situation you're talking about. Great question. Okay, well, thank you all very much for participating. Always a joy to be able to present to you. Hope everybody has a great day. And I guess I will stop sharing at this point and leave. So have a great day.